Please welcome Mike Sicilia to the stage.
Good morning again, and thanks again for being here. Thank you for your partnership, your investment, and specifically in these few days, thank you very much for your time. We're going to be joined here by some really inspiring healthcare leaders in just a bit to have a discussion on everyone's favorite topic, AI. Before we do that, I thought I'd share with you just a little bit of our thinking about what we call applied AI and how we think it can be used to really enhance clinical operations. And we think about that in the context of really three buckets or three areas. The first is automating routine tasks, where you've seen a lot of attention today on the AI space. The second, emerging and certainly lots of technology being developed across the industry for clinical decision support. And then finally, precision health and wellness. So thinking about routine tasks, we're at a point with AI where we can ingest and interpret very large amounts of data very, very quickly and deliver it back to a provider in a very clear and efficient way at the point of care. And the biggest impacts that we've seen in these areas today are with AI-assisted documentation, which reduces the amount of time spent on administrative tasks, image analysis, improving text search for medical records, and more recently, using voice as a navigation tool, as we've unveiled the Oracle AI agent, clinical AI agent. Now, voice has long been present in healthcare as a dictation tool, which is interesting, but perhaps not as compelling as it is as a navigation tool. This particular technology, using voice, using natural language as a navigation tool, has really unlocked, and we've seen the results, unlocked the sheer amount of time that providers are spent clicking with keyboards today. And all of this is done, of course, to reduce cognitive burden and avoid provider burnout so that they can continue to deliver the best care. If you will, in the future, I don't think the future is that far away. Seema just shared the timeline for it here. Much of what you know as an EHR today, much of what you know with the screens will completely disappear into the background. The primary interaction with the EHR, everything from biometric sign-on to placing orders, will be and can be through voice. Secondly, in clinical decision support, the key question that we're trying to answer is here, how do we get the very best intelligence into the hands of the provider in the moments that matter? And of course, that is at the point of care. And this can happen in a variety of ways. Advanced documentation tools to support updates and consultations on the go, streamlining chart reviews to help providers quickly analyze past visits, more rapid test and image analysis to be able to reach a diagnosis earlier. In essence, it's taking everything we know about the patient, from interactions, patient history, medication, past successes, and delivering that at the point of care. And the key word here is everything. It's everything about that patient. You know, whether that's relevant to the last 5 visits or visits that date back 20 years. You know, whether it's relevant to something that's directly in the EHR or other systems that we're connected to. And this is really the power of AI. This requires a couple things. It requires large language models, which are at the heart of generative AI. It also requires supercomputers. It also requires supercomputers to be able to do this very, very efficiently. This is, you know, a lot of what providers spend pajama time doing today, doing research, doing clinical research, finding out how they can help a patient by doing lots of research. There's no reason, and there's no technical barrier, that we can't do this at the point of care. Not only do we want to do this based upon this particular patient, we also want to be able to compare that patient to patients who look like that patient from vast amounts of anonymized data that we have access to at the point of care. Key point, though, as Seema said, we're not here to replace the provider. That is not our mission. That is not our goal. That is not what we do. We want to provide the very best tools for the provider at the point of care by being able to power very large amounts of data very, very quickly. And then finally, you know, emerging area of precision health. Precision medicine, genomics, pathogen sequencing, customized medicine are all areas where there's terrific AI progress being made. Things like portable and low-cost genomic sequencers, molecular discovery in health sciences, better clinical trial patient matching, and this idea of always-on intelligence is really taking hold. So I think, in short, we're at a revolution of how healthcare and life sciences engage with data. And that really should pave the way for enhanced care coordination and real-time actionable insights. And what I can tell you is that even 18 months ago, maybe even 12 months ago, maybe even 6 months ago, this revolution would not have been possible. We continue to innovate in terms of AI. We continue to innovate in terms of the amount of computing power, the amount of energy that you need to actually pull this off. And I think we're going to see some very amazing breakthroughs. We've seen terrific things already with the clinical AI agent. Very excited about what is to come. So with that, I hope that's just a little bit of a background before we enter into the discussion. I'm going to be pleased here to welcome on stage in just a minute Don Calcagno. Don is the Senior Vice President and Chief Population Health Officer at Advocate Health. Bill Miller, who is the Chairman and CEO at WellSky. Shamshur Vailil, who is the Founder and Chairman at Burali Holdings in the Emirates. And Sally Deitch, who's the Executive Vice President for Nursing and Operations Infrastructure at Ascension Health. So with that, please give a warm welcome to our panel. Thank you all so much for being here. So, I'll start with a question, I guess, for everybody. AI, as we've heard, has huge potential to reduce complexity in healthcare and really help us meet the needs of both payers, providers, and most importantly, patients. As you think about this specifically in your organization, and you each have a very unique organization in terms of healthcare, what do your teams need to do internally to unlock its full potential? I'll just go right down the line, Don, and start with you.
Great. Now, in my world, we talk a lot about value-based care, population health. So when you think about the complexity of a managed care contract, there's a lot of things behind there that, hey, how do you actually optimize that contract? So AI has a huge potential on the contracting side. It also has a huge potential on helping our primary care physicians. So if you go back to what do our teams need to do, we need to get all that data. We need to get it in the right place. But as Seema said earlier, it's less about storing that data. How do we add intelligence to that? And what we're excited about with HDI is how can we bring intelligence to all that data we've been collecting all these years? Perfect.
As a technology company, if you ask how we are trying to unlock it at WellSky, first of all, I think it takes organizational commitment. I think similar to Oracle, we're kind of all in on AI, and what that means is a lot of investments. So it's taken a fair amount of like supercomputing, as you mentioned, and licenses. So we license all the tools for every one of our 900 developers. And I don't know many organizations that have done that. The idea being, let's get them the tools and let's see what happens. Secondly, you got to have organizational buy-in. Of those 900 people, after a month, only 700 have claimed the licenses, and if you looked at what was going on with those other 200, it was, I don't see the applicability to it, our tech stack is different, our workflows are different, that sort of, inherent resistance to change. But I think part of the way over that is the third dimension is give them real things to work on, real life problems that our providers are facing in the post-acute space. And like Oracle, we've implemented ambient listening to speed up all the senseless time we spend on documentation, all the mundane things that can be automated, and we've seen that drive adoption and commitment, and I think it's just, impregnated all of our developers to think really creatively. So I think with these type of technology changes, there's got to be an organizational commitment to it.
Mike, good to see you again. Since I'm the only one outside of the States, I would like to explain a brief on where I come from. We are based out of an emirate called Abu Dhabi in United Arab Emirates. where the population of the country is only 10 million, but we have free trade agreements with almost countries with almost 2.5 billion population. So for us, it's always been very fascinating to see how we can simplify healthcare. And I think AI, for me, is a tool that can make healthcare delivery less complex. We always have deliveries across GCC, Africa, and India, where we operate even in some of the most difficult places in the earth right now with the geopolitics and whatever is going on. So for us, it's a tool to enhance our physician productivity, and for that, we have to win the trust from the physicians. As I think the Seema mentioned, Mike, you said, we are not in the business of replacing the physicians. We want to make sure that they get more empowered to take the right decisions in the shortest amount of time. So for me, it's all about simplifying healthcare, making it less expensive, and taking it to difficult parts of the world where people are devoid of healthcare.
I think for our organization, and there's a piece of saying, this is what happens in a hospital day to day. But there's an actual deeper place to where AI can go in the future, and that is, how do we look at the communities we're serving? How does this start? How do we take and really synthesize the data that goes from social determinants of health all the way through the life cycle to when a patient is actually in a hospital? So how do we start impacting the community, overall health of our population, versus just saying, we're going to deal with you when you're sick and now you're in the facility? So it has the potential to really take and revolutionize the way that we approach healthcare in the United States by becoming more preventative and actually addressing what are those social needs and barriers that are impacting the health of our communities.
Yeah, it's very interesting. You all touched a kind of on an underlying theme of change management needed as well. I mean, arguably the technology is easier than ever to implement. Things like our clinical AI agent require very little training to use, but how do you get it into the hands of the providers, and how do you get them to trust and accept, and what's the change management needed behind that? I want to come back to Dr. Shamshir for a second. You started to touch on this a little bit about the uniqueness of Burali, particularly with your operations in the Emirates, but maybe you could just give us a little bit more of a background on Burali and what you're doing across the world, because you've got a very diverse and interesting portfolio of organizations to change healthcare.
So we operate in 3 verticals. One is the pre-hospital care, where we do a lot of remote patient monitoring. We have a lot of clients like the energy sector, where we are handling exclusively the oil companies, the energy companies in and around the region. So that is one element which is focused on pretty much remote patient monitoring, emergencies, fire and safety, and the health and safety environment of a larger workforce. The next vertical is the hospitals, which we own and operate around 19 hospitals, and then we manage a lot of hospitals across Africa, and we own hospitals across India. So what we have seen typically when we started the first hospital in 2007 is a hospital is a very bureaucratic place. Everything revolves around the physicians, and then it's very difficult to implement the change. Whether even we are going through the Cerner implementation right now. So what we are trying to do is make it like a celebration mode rather than giving too much hope to the doctors that it's going to make life easier and stuff, but it's about making the lives of patients better. And that has been the vision from day one. We thought that we should make the quality of life for the patients as much as we can. So that was the founding principle of what we did. And then we have the pharmaceutical manufacturing, where we have a US FDA approved factory from Dubai, where we export to US and Canada. So for us, the most interesting part of the equation is how we look at data, because we have patient in the center, we have clinical trials happening at any point of time, and the big pharma mostly interested in the US and Europe, so we have an advantage of taking the rights for the region, doing a contract supply for them to the US. So for us, it's always been decision-making at the center. For whatever bureaucracy, we want to break it, we want to move fast, we want to bring the doctors into confidence. So again, that was the founding principle of what we did. So this is a brief of what.
Yeah, I can tell you from experience that Dr. Shamshir is a very hard person to keep up with. He's always got something new brewing. But I think what you've done is really focused on solving the entire problem, everything from supply chain through clinical delivery. And you've got solutions along there. And I think it's an approach that is needed. You've got to rethink, as we like to think, we've got to rethink about every single step along the way. EHR is certainly a big part of it, but the thinking that we've explored together has gone well beyond that. So we certainly appreciate that partnership. Bill, I'm going to come back to you. On the tech side of this, being CEO of a large technology provider in this space at WellSky, you see lots of pitches on AI. I mean, there's some part of everything's AI today, and maybe some of it's not so AI. How do you determine what's good, what's real, what's worth pursuing?
Well, we've been acquisitive, like Oracle, and it is an environment now where there's 1,000 startups, and they're all approaching all of us about what they can do and how they can revolutionize healthcare. And there's no doubt there's great innovation going on that front. But of an organization of scale and with 20,000 different clients, we kind of are very careful about what we do, all the while being very committed to what AI can do. And getting through the hype, we just break it down real simple. From an internal perspective, we use these tools. Our similar to Oracle, our foot is all the way on the pedal. So anything we can do that can speed up our own development, that can speed up innovation. For example, we're at the earliest innings of this. After about 1.5 years of having every developer have license, but we're generating on a daily basis 5,000 lines of code that no human has touched. And the quality of it is outstanding. That is freeing up tremendous resources to work on the next generations of issues facing our clients, which is the external kind of funnel we look through. It is, what are we doing that's really going to change and revolutionize and make things simpler for the providers out there? And for example, some of these forms that people have to fill out for hours and hours and hours, and all this pajama time documenting, we've squashed that down to minutes as opposed to days. So we really just, our compass is set on what the clients need, and those are all determined by what pressures are they under. And nothing sort of rivals the workforce issues in the post-acute space. They just can't hang on to providers long enough. So any branches of that AI can help speed us up. And then the third dimension we look at, and this is the one I think we proceed with the most caution, is clinical decision support and keeping a human in the loop and not developing any unintended consequences around clinical decision support and ending up on the front page of the Wall Street Journal for it, quite frankly. So being really smart and understanding that is a sacred relationship between caregiver and patient. The technology can enhance that, can speed it up, can make it more accurate, but as Seema said, not with the intention of needing that human in the loop to make those close calls, to observe the things that a machine, quite frankly, can.
Yeah, I think you make a great point, too, on code generation. One of the first things you said, we're at a place where we can get things to market far more quickly than we ever could in the past. I think one of the key points is, how do we have the change management in place so that people can consume it just as quickly?
Yeah.
Because if you look at the average age of infrastructure today, in our customer base, and I think in the healthcare system in general, for core assets, it's pretty old. By cloud standards, it's ancient. And that's going to be something that I think is a fundamental shift, to move to smaller, more iterative consumption and move away from these large, big bang, all-in type implementations. And it requires a bit of work that we all do.
And I think
together.
just not stressing that it's AI, just stressing that it's innovation.
Exactly right.
Full stop.
Right.
Yeah.
Once AI disappears, then we know we've succeeded. Once the word disappears, we know that it's innovation baked into the applications.
Right.
I think we've succeeded. But we'll stay on the AI theme for a second, Sally. Speaking of consumption, and speaking of benefits, what are you seeing? What are you seeing in the units today? What are you seeing on the floor today among doctors, nurses? Is there any benefit that they're getting today from AI?
Oh, there's absolutely benefit. I think, and everybody's pointed to it, whether it is ambient listening, doing the notes, summarization, all of those pieces are making a big impact. And even all of the different trials that we're running, the physicians are so engaged and very appreciative. And, we have physicians volunteering all over to say, yes, let me try it, with a pretty successful adoption rate. I think The future is how do we look at the nursing workflows? How do we consolidate that information? How do we take the mundane of filling out flow sheets and different forms, and how do you take that and get rid of it? And really allow the nurses and the physicians to focus on practice, but with the synthesis of data. And I think that's where there's really so much benefit to what we're seeing with AI. Being able to take a longitudinal record and consolidate and actually say, these are the key things that you really need to focus on with this patient, and as they're sitting, whether it's in the clinic or they're actually in the facility at that time.
And I'm just curious, as a follow-on question, how has the reception been? How's the attitude been towards these AI-enabled features among your clinical workforce? Are they suspicious? Are they excited? I mean, what's the mood?
Yeah, they're very excited. What we have found, and I think I shared with you yesterday, that we know that 70% of our workforce has never documented in a paper record. They've always had some kind of an electronic record. They're also generationally a group that says, where are the new features? I update my phone and have new features. What are you all doing? So we literally have people, when we roll out a pilot and say we're going to try this type of ambient listening, or we're going to try this kind of documentation synthesis, have people volunteering and saying, I'll do it. Whereas if I think back 20 years ago, we would have to pull teeth to say, can you try this? Because people were so ingrained in the way that they had done things that generationally, this is very different, and they're very willing to experiment and to try something new.
Yeah, do you think it speaks as much to the difficulty they're having with the current systems, and that if there's a better answer, because you mentioned yesterday some stunning stats to me about the number of providers who've been signing up to sort of beta test AI features versus trying to get them to sign up to beta test more traditional features. I think it's been a much longer slog.
Oh, yes. Oh, yes. I do think that, where I see integration not only within the healthcare system, but I think the questions we need to ask is, how do we take the innovation to the schools to say, how are we working with training programs as we're matriculating doctors or nurses into the fields? How are they helping us to get to that next place as well?
Yeah, when we spoke yesterday, you shared with me, that in schools today, students are in medical schools, or nursing schools, students are spending just a crazy amount of time learning how to use very antiquated systems today, and it's a core part of the curriculum. In other industries, other vertical industries, where we have, skilled labor being trained through university, I can't really think of one, and all the other industries that we serve at Oracle, where the students would spend as much time learning how to use the system. And they're sort of learning a protocol at the same point, too. It's not just about learning a system, but they're learning a methodology, which is a bit static. So how much training have you had to do for your existing providers to be able to uptake new AI solutions versus how much training would they spend on a traditional EHR, shall we say?
Not as much, because it's been very intuitive, which is a big change. If you think of the traditional EHR and the training that goes into that, if I look at traditional orientation to any EHR training, you're talking days and days and days, and that's just foundational. So the introduction, and with AI, I think that is one of the benefits. It's very intuitive, and it's bringing in the data sets that they would be looking for. So I think there's a piece that as technology advances, it's also going to show where so much of our traditional EHRs have really, in many ways, they are antiquated, and they were built a long time ago.
It's funny, when we first acquired Cerner, it was a little bit of a step back in time because we were going through the process of integrating Cerner into Oracle, and was meeting with a team that told me they do classroom training. They actually have classrooms where people come to get trained on how to use the system. And I hadn't heard that in our other vertical industries in a very long time. And then I saw the system, and I said, well, it actually kind of makes a little bit of sense now. I see why. So, I think that this idea that, and I just think, look, in general, technology providers, by and large, at least on the big core asset side, haven't done a great job at serving the healthcare industry, right? I mean, obviously the industry deserves better, patients deserve better, providers deserve better, and you can really see the tide starting to shift now. You can really see, getting into this idea that maybe it could be just as easy as ordering. Why does it have to be so hard to use the system? Why can't it be just as easy as ordering something on an e-commerce site? I can tell you, there's no technical reason that it can't. But we need help to get people to accept and to believe that. Yeah. Well, anyway, shifting gears just a bit to the back office then. Ascension was the very first customer that we partnered with when we talked about integrating ERP and EHR. Doing both together. And I know you're along a journey on that. What do you see is the potential for this integration in the long run, maybe in the short run as well, both for Ascension, but for the industry in general? Why is this so important for you and part of your mission?
Well, we have made a big bet on Oracle Health, as well as so from ERP implementation that goes from HR, finance, supply chain, workforce management sitting in the middle of it, to the EHR. We have made a big bet. And it's been very important for us as we're thinking about the future of our ministry, the future of what healthcare looks like to us, of how do we take all of this information and honestly, it's very focused on the talent within the organization. If we give people a great place to come work, that it is not hard for me to do my vocation because I'm not having to fight through, I don't have the equipment, I don't have the supplies, and I don't have the technology in order for me to do what I do, what I come to serve, and that is caring for patients. We look at this and say, how do we create a seamless approach? How do we take the pain out of this so that forecasting is easier? And if you think about where this could go long term, the ability to really take documentation to say, how does that affect supply chain? When do I know that I'm running low on these supplies, or I've used these supplies on this surgery or during this kind of case? So it ties together longitudinally from how do I hire somebody and onboard them into the system, that it's not just how do I provision you and how do I get you access to the systems, but then how am I training you on the systems, which are all tied together, to how do you schedule and get scheduled to come to work, to how does that feed into what the staffing looks like on the units. You can take this and weave it through in so many ways. And so to have that combined EHR, ERP platform, the power of that, we just think could be limitless.
Yeah, you've obviously led the thinking on this again, as I referred to Dr. Shamshir about solving the whole problem, and if you can do that well, I think there's another benefit where you actually end up spending less on IT costs on these things combined, and that's money that you can return. These are not small dollars that you can return to your critical care units, your operating theaters, your surgical units in general. And these are the start of the conversations that we're starting to have. And I think that the way healthcare buying processes worked, and this is not unique to healthcare, but I think it's especially acute, no pun intended, in healthcare, is that there were a lot of stovepipes and a lot of pillars. And the cost of integration of all these systems is a hidden cost that is, I think, often overlooked. And it's also obviously a tremendous cyber vulnerability, in my opinion, as well. So kudos to you for leading a lot of the thinking on why it's important to look at the entire ecosystem of IT, not just the clinical systems as well. So Don, I'm going to come back to you. So part of your core mission at Advocate is to reduce inequity in healthcare. We've spoken a bit about AI in the back office, a bit about AI in the clinical theaters. How do you see, and what is the role of AI for helping you advance this mission for reducing inequity?
Yeah, I would say across the country, we've all realized that there's this health disparity, right? And my definition of that is, if you think about, there's these subpopulations that are having health care that's lower than the rest of the population. And if you think about it, it could be race, it could be ethnicity, it could be a zip code, right? So if you begin to think it's going to be a feet on the ground solution, but how are we combining the human intelligence with that artificial intelligence? So how do we know what the problem is? Is it access? Is it affordability of medications? Is it some social determinant of health? So how do we get after that? But the way we think about it at Advocate is it's core to our mission. But if you think about it more broadly, we want to bring those subpopulations up to the population, right? We want everybody to get there. But the broader problem is that population isn't where it needs to be. So fortunately, the solution to move the whole population, including the subpopulations up, is where we look at health data intelligence. And the way I think about it is we need to get really a lot better on predictive intelligence, prescriptive intelligence, and automation. And I'll tell you what I mean by that. Across Advocate, we have 2.4 million value-based lives. That means 2.4 million people that are in some type of contract where we need to improve our quality and lower our total cost of care. So make it better for the patient, better for the doctor. If you think about most healthcare organizations in this country, if you're using care management to do that, you can touch about 1.5 to 2% of the population. So take that 2.4, that means we're touching 48,000 people. What about that other 2.35 million? Some of them certainly need to be touched, right? It's a human capital problem. There's not enough human capital to do that. So in our view, this is where you have two ways of solving it. One, predictive intelligence. Of my 2.4 million patients, who is the most next impactable patient? So you can almost array those 2.4 million from most impactful and most needed to least. And then once you know who they are, we think of prescriptive intelligence. Okay, based on all the evidence that AI can consume, based on past actions that you've done for these very unique patients, hey, I have chronic kidney disease, I have hypertension, I have this, I live in that zip code. What is the next best thing I can do for that patient? And then when I go have a care manager reach out and talk to that patient, I can use generative AI to summarize it so they don't have to read through a medical record. Well, you see how old I am. Medical record like this, or I guess it's a digital one now. Right? So it really makes it effective to go after those patients we're going to touch. But that still leaves my problem of the 2.35 million patients. Even if I make it more efficient because of automation, say instead of touching 48,000, I'm touching 100,000. I still have 2.3 million patients. Now granted, there's a lot of healthy 26-year-olds in that population that don't want to talk to us, don't need to talk to us. But what about the ones that do? So when we think about that, that's where this clinical agent that everybody's been talking about, right? How do we reach out to those patients so that we can lower the water level and see those patients that actually need to be turfed to a doctor or a nurse, et cetera? So we think about HDI as the core principle of being able to help us identify the right patients, identify how to go after them, and how to improve it.
You spoke about HDI, which, in case you're not aware, is our health data intelligence platform. And I think what you're doing there is really bringing together, healthcare and public health, almost, pseudo public health, at least population health among your base, into a single platform. And this is a really interesting when you talked about predictive, the predictive piece of this thing, and who may become the next sickest. What's the best thing that we can do? And this has been a big shift for us, and Seema alluded to a lot of this in what she said, as we think about redesigning these systems from systems of record to systems of intelligence. Our view when we looked at the EHR systems in general was that they're very good at telling you what already happened as designed today, which is interesting for billing reasons and things like that. It's not, I don't say that to be completely sarcastic, but it's true. They're very good at telling you what already happened. Not so great about telling you what may happen and what you might want to do for this patient. Same thing with traditional analytics systems, where they're very good at aggregating a bunch of data that's already taken place, but not so good at making predictions about how those things, how those things may impact outcomes going forward. It's the AI piece of this, and the neural network piece of this, and the what-if scenarios that do require, as I said earlier, these supercomputers to be able to compress it, that get you to a much better space. I mean, I guess the follow-on question is, how's the data access been? I mean, have you been able to get all the data that you need to pull this off easily? I'm sure it's been a piece of cake, right?
Right. So I'll give you a little bit of history. So at Advocate in Illinois, we were one of the folks that founded and actually coined the term clinically integrated network back in the early 2000s. So we've been doing pay for performance since about 2003. So it started on paper, then we moved to Excel, then we moved to SQL Server. Then we worked with Cerner to co-create Healthy Intent. But to your point, those are all systems of record.
Yeah.
Right? That was getting the data in. That's why I'm so excited about putting intelligence to that data. So we've had a history of trying to do that. I heard SEMA say 3,000 inputs. I want all 3,000. We're not quite there yet. But if you think about the data coming in, we have been using Healthy Intent since about 2011, I want to say. And we have roughly 40 different data sources, hundreds of feeds, and that has been incredibly important. But again, we need to add intelligence to that. People used to say data is the new currency. It's not data, it's intelligence. Yep. And because workforce is such an issue that we've all talked about, we don't have enough human capital. How can we leverage that intelligence to serve our patients?
Yeah, and I think you've been proof that systems of record and systems intelligence don't have to be two different systems, right? We can have them in a single system, and that's been I think another huge breakthrough that we've seen with AI. So thank you very much for your partnership and helping us make HDI much better as we go forward. All right, so I'll start with a question for all, and I'll start with you, Dr. Shamsher. You've done a lot with AI already. You're doing a lot. You've got a lot of plans. You've announced a lot of things publicly. What do you think is the greatest opportunity for AI going forward? And is there anything that we haven't mentioned or haven't thought of yet that we should be thinking of going forward?
So I think we put something behind us that is COVID, which has taught us a lot of great stuff and a lot of very simple stuff. I think something that we all learned during COVID is the art of repurposing. So for us, if you look at the entire ecosystem, what is missing is that everything has changed except the curriculums of becoming a doctor or a nurse. It's still the old version of going through that 15 years of intense training, and AI not being part of the curriculum is a major drawback. And the problems that we are facing now, including mental health issues, which are like on the verge of explosion, is something that is not very much addressed, because the amount of workforce, that is where I think the AI opportunity comes. When you don't have the talent to solve the problem, I think that is when a doctor can be multiplied into 10 by using the tools that is required. So I think we are the right time, and what we are missing is that change management adoption. We have some great computing powers. We have a lot of new research in pharma. But we need more do tanks than think tanks. We are all discussing and not deliberating what is required to democratize healthcare. Because what you see is the big not-for-profit hospitals across US, which cannot be scaled. If you take any of the successful units outside of US, they have a problem because they try to plug and play, and the problems outside are pretty much different. Where we operate, our problems are pretty much different from the problems here. Most of the trials happen in US and not on the genomes that we are. So we feel that democratizing healthcare, and I think people like Oracle and Cerner play a big role. We have seen the ease of dealing with the people has changed as well. So we took, for example, 3 months to close a contract for the whole deal. So normally we put a lot of time for nothing. If you have a playbook of scaling up, so we are now trying to not to build massive hospitals. We want to bring people back into the community. So we are trying to do ambulatory surgical centers. We are trying to make sure that a patient visit to the hospital is only for absolute purpose. So for us, it's, again, as I said, simplifying healthcare, reducing the complexities, bringing doctors to discuss, winning the trust of the doctors, changing the old mindset. We are in the new world. The new generation doesn't understand what we would have gone through. If you explain it to them, they would never get a clue of what is the real world right now. So I think the speed to change is going to be intense. I think who can survive, fasten up the buckle up, and I think it's going to be a bumpy ride.
Yeah, it's a great point, because, like you said, the speed of change is just incredible. Right? It's incredibly rapid, and the ability to get this in the hands of providers quickly is even 6 months ago, it wasn't as dramatically impactful as it is today, and that will continue. Right? We'll continue to see a hyper cycle of innovation here. So we appreciate you helping us lead the way there throughout many parts of the world. Thank you. Sally, save the question. What are we not thinking about today with AI? What should we be thinking about?
I think Seema kind of touched on it in her last comments, and when she was talking about the art, the art of healthcare. These are healing arts. It is what people went to school to learn. It wasn't just the science behind it. There's an actual there's an art to it. And I think it's the marrying of the tech with the art. And so how do we create, instead of just saying, we're going to teach you the algorithms, we're going to teach you how to follow this path, and something's going over here is going to synthesize all this data and tell you the path to go down. How do you marry that algorithm and that path with the actual art? And really focusing on this actually will enable you to practice the art with support and synthesis versus the other way around of saying, here's the algorithm and the path you should go down. Oh, by the way, and you happen to be a doctor or a nurse or a pharmacist or a physical therapist. It's taking those two. And I think that's a little bit of the old school plus the new generation coming in to be able to really interpret and to hopefully help Oracle to build that.
You mentioned that 70% of your staff had never documented, on paper before, all used to electronically. So arguably, they've been part of a generation of providers who have been probably a little bit burdened or taxed, as Seema said, by the adverse effects of these first-generation digital systems. Getting back to the art, getting back to the art of caring and healing, do you think this will happen naturally as the systems become more, more ambient, more in the background, or is this something you actually think you need to teach as a skill across your system?
I think right now we need to lean into the generations that are leaving and aging out, because there is, say, 30% that they know how how you did this before, how things were accomplished before you had a computer to even tell you what was the next step. So before we lose a generation or a couple generations that had a very different experience when they learned the art and were taught that, I think we have an opportunity to bridge the two before we basically go to, there's no one that really has ever done this without having a computer. And so I think we're kind of at this, whether it's a sweet spot or not, of being able to marry those two together.
Very interesting perspective, and certainly love to continue to hear how it's going. Bill, what are we missing with AI? Everybody's excited. You're excited. We're all excited together. Lots of progress. What haven't we thought about yet?
I don't know that it's not that we're missing it, and I'm a bit of a closet optimist in my real persona every day, particularly in the context of value-based care. Whether I was at United and Optum or now WellSky, working on that problem of fluidity of data and sharing data and true interoperability has been like making diamonds out of carbon. It has been a pride-swallowing siege for the last 20 years, and I've been at the middle of it with big providers, big payers, and still we're having to deal with these huge tolerances of making it work and making it work clunkily. The optimist in me just watches my kids work in a way more frictionless world than I grew up in terms of data, access to things, communication, sharing, transparency. It's crazy. So I don't think we're missing it, but we're frankly looking at our workforce generationally and trying to figure out, you can say bad things about Gen Z, millennials, but if you look closer, they probably help unlock this at scale than, frankly, what most of us have done in this room. And I include myself in that evaluation. So how that really pops out, I don't know, but there's an inevitability to it. I think there's just an inevitability.
Yeah. It's a great point. Yeah, my son's a data scientist and in doing rare disease research, and I see the optimism in him. As a 27-year-old, where he's not been part of the system where he's been burned. He does complain to me a little bit about EHRs, though. He does say these things are not so easy to get data out of it. Well, I've heard a little bit about that problem. Yeah, but
hopefully they'll be in charge by the time we hit the hill.
But he's but to your point, he's used to a frictionless world, and he gets thrust into a little bit of that friction when you look about data sharing and things like that. And it's interesting to see his reaction is, well, there's no good reason that this friction exists, is there? And I said, no, there's not a good reason. Yeah, there's actually not a good reason. There's not a technical reason it exists. So, I think great points. Don, you get the last word. What are we missing?
When I think about the challenge in healthcare is the healthcare value chain, call it ecosystem, whatever you'd like. So it's encouraging to hear how Oracle wants to bring in life sciences, device manufacturers, et cetera. But when you think about it, it actually starts up there at the payer and the provider creating networks and contracts. Managed care contracts, incredibly complicated, right? That's where revenue comes into our system. Then layer on complex value-based care terms. It gets really complicated, so much so that sometimes the payers don't even understand what they are. So if you think about it, if you begin attacking that ecosystem, we begin bringing intelligence, and kind of like Bill said, we bring transparency. Now we can try to take that game theory out of the ecosystem so that we can actually work on what's going to improve healthcare. So to me, that's super exciting. And honestly, as you build out the ecosystem and bring in pharma, bring in medical devices, I think we're at the tip of the iceberg and we don't even know what we can do with that. But to me, it starts with getting that game theory out. That starts with the contract intelligence, where just leveling the playing field, making sure, most healthcare executives have never seen a managed care contract, right? I negotiated them for years, they're complicated. How do we translate that to simplify it so folks know what's coming in, how the payers maybe are manipulating things? How do we optimize the contract? Again, predictive prescriptive intelligence will help us do that. But the future is even more exciting because once you begin bringing other players into that ecosystem, there's things I don't think we've even thought of yet.
Well, thank you for keeping the optimism very, very high. Sally, Dr. Shamshir, Bill, Don, thank you so much for your insights and your partnership. We really do appreciate it.